Well, let's get started on time. Good morning, everyone. I'm Larry Boris, the Executive Director of the National Association of Worksite Health Centers. I'm pleased to have with you today a presentation relating to best practices and what we call a click and mortar strategy, or how to integrate in-person and virtual care. With us, we have three speakers today. If you go to the next slide, please, Paul. We have Hassan Azar, Executive Director of the Employers Health Innovation Roundtable. He's former Global Head of Total Rewards for U.S. Foods, Mondelez, and I will also say Ford Motor Company, and others. We've gone back a long time with Hassan. Dr. David Cameron, Chief Medical Officer of Hint Connect, who's a primary care physician at Pure Family Medicine. And our moderator for today, Paul Marcotulio, partner at the Yellow Brick Strategic Advisors, and he was a former global head of benefits at TD Bank and Citigroup. So with that, I'll turn it over to Paul. Paul, go ahead.
Thanks, Larry, and good afternoon or good morning, everyone, depending on where you are. When Larry and I first spoke about this topic, we really started to think about what is it that we want to discuss. And why is this an important topic? And it really stems from a conversation Larry and I had about a year ago around some work we had done with the business group on health on looking at virtual and digital healthcare and its place in the market. And then how does it fit, and how employers are thinking about it, and where do we go from here? So based on that, we wanted to talk about the outcome of that work and the fact that integrated care was a big piece of what we learned as we did this study and talked to employers, employees, health plans, solutions, consultants and brokers. So a big range of people that we spoke to, and there was a lot of outcomes from that we thought were very important to touch on, and was the basis for what we're going to discuss today. And really what the outcome was that employers are still struggling today after so many years of attempting to address various needs of their employees and balance the cost of care with little success, frankly, and a lot of frustration. And employers really are looking at healthcare from multiple lenses and trying to address this, what we call triple aim of healthcare, right? Access, quality of care, and cost. But unfortunately, by looking at it through all these different lenses and thinking about and utilizing various solutions through the years, employers have actually exacerbated the problem and unknowingly and inadvertently, and have we've evolved to a situation, a system where we have so many solutions out there that employers have been looking at that there's an average, I just want to say somewhere like 10 to 12 healthcare solutions that employers are utilizing to try to serve their populations, right? Over the last 7 to 8 years, we've seen a huge influx of point solutions and healthcare solutions. There's over 11,000 solutions today. And employers look at these solutions from various standpoints, right? For telehealth purposes, for primary acute care, teletherapy and mental health purposes, chronic condition management. And as they've looked at all these solutions and adopted them, and as we all know, that has expanded during COVID, it's actually caused more fragmentation, a multitude of touch points and confusion amongst employees. And for those reasons, we feel that trying to look at integration of all those components and trying to bring that together in a thoughtful and in a comprehensive way will help employers evolve so that they address some of these issues and shortcomings that continue to plague them around disaggregated care. Now, why is that important? Well, because fragmented care is expensive, right? It causes a tremendous amount of friction in the system. Employee satisfaction, employee experience is poor, and the care itself is actually not high quality. So one of the things that we've determined is that there's this need to think about it from a standpoint of all the pieces across the continuum. So in person, on site, virtual and digital, um, and even in at home. But in order for that to work, there needs to be a quarterback or someone who can really understand the individual and the employee's needs and issues across those spectrum of care and help to pull that together and deliver that in a way that is comprehensive, but also very specific to the organization and the individuals within the organization. So that's what we're going to talk about today. And then we'll talk about at the end ways to address that. What best practices, what are some models already in place that will allow us to start to think about this in a way that gets us to that desired state. On that note, I will pass it on to Dr. David Cameron, who will talk a little bit about the implications and a bit more about why this is an important area and why fragmented care is an issue. David, over to you.
Great. Thanks, Paul. I have participated in the fragmented care. I've had two halves of my career. My first 10 years were in a fee-for-service multi-specialty primary healthcare system. And then the second half have been with direct primary care, and different experiences. And so I was just going to highlight a little bit about what my experiences have been in both places and how one was quite fragmented and the other one was not, and how that has impacted the patient experience, the quality, and the cost of care delivered. And so for the first 10 years, I was employed by the hospital system, and I was assigned a panel. It was a little over 2,500 patients, pretty standard for a primary care physician. Uh, they scheduled me about 34 patients per day, and with no shows and some people were rescheduled, I would usually see about 28 to 30 per day. And then I was instructed to minimize the number of visits, or excuse me, the number of problems per visit to 1 to 2. And so I'd have to negotiate with my patients ahead of time and say, okay, what one or two problem are we going to talk about today? Otherwise, we're not going to have time to address those issues. And my schedule was full, so I was about 3 weeks booked out. So patients couldn't get in to see me unless they booked out for 3 weeks. And so the problem is it just sets up an access problem. And so if patients would need to see me urgently, they would need to go see somebody else, unless I had a cancellation. And so that meant that they would either go to urgent care, sometimes the emergency room, sometimes it would be a virtual solution, Teladoc or American Well. And the problem is if they start going to those other places, it ends up being more expensive. As we all know, that emergency room urgent care is more expensive than the primary care solution setting. And the other thing is that we have we refer to farming. So if someone comes in and they got 5 or 6 problems, let's say they have got diabetes, high blood pressure, high cholesterol, they may have some orthopedic issues, they may have some asthma, and if they want to address all of them and all of them are sufficiently urgent, what I might do is I say, well, gosh, I don't have time to address all of those issues. What we might do is have you go see a pulmonologist, a dermatologist, endocrinologist, and have them have fragmented care and see specialists. And so what happens is you end up having some overuse. One specialist may order the same test that another specialist orders. Sometimes you get one specialist that may order a medication and not know that that interacts with a medicine that another specialist ordered. And there may be interactions. This can lead to side effects, and sometimes this can land the patient in the hospital. And sometimes it's a little bit difficult to know exactly where patients are going. There was a study by the American Journal of Managed Care, and they looked at cost, and they said this is a study with 500,000 patients, and in the top quartile of fragmented care versus the bottom quartile, it was $4,542 more expensive for the fragmented care, and it's worse quality. Plus, patients have to pay more copays. They've got more co-insurance. their experience with that. There's lots of studies with inpatient, outpatient, emergency room visits that show the quality of care is worse in a fragmented system, and the cost is much more expensive in each of those different scenarios. So if we take a look at the next slide, here's a schematic. And so oftentimes patients don't know what to do. And if this is their healthcare system, at the top they might have their general practice, but they might have a number of specialists. Maybe they've got a cardiologist, a pulmonologist, a neurologist, and they may lots of patients I see for the first time that they've never had a quarterback, they've never had a primary care physician. And so what happens is that each different specialist has an incomplete part of the patient picture. And like we talked about before, there can be duplicate medications, there can be interactions between those medicines. Some systems are not integrated, and so some specialists are not in the same system. They don't have the same electronic medical record, and so oftentimes it's difficult to get the records. We oftentimes see the same studies that are ordered multiple times, and then there's episodic acute management that happens in the wrong place, and then there's this rise in virtual solutions with mental health, with MSK is quite common as well. And then sometimes patients get confused because they get conflicting advice from the different doctors. It's one of the problems when you get too many cooks in the kitchen. And so this is what we've seen. And what I like to do is talk a little bit about how we are thinking about things, about how things could be better. So if we take a look at the next slide, this slide are some principles that we can consider that can lead to decreased fragmentation and better integration of care. And so what we'd like to have is a system where patients have a go-to. They've got a phone number, they've got a person, one place that they go to, that they know that they're going to get the advice, that they can either get the care there or the direction to the right place. Sometimes patients don't always know where the right place is. Maybe they think they need to go to the emergency room, but then they talk to their quarterback and they go, you know what, this can be dealt with at the urgent care, and it can be done in a more timely fashion and less expensive. And what we feel that patients, they should get their issues, if it's an urgent issue, to be managed that same day or the next day. And best to have some type of a digital or virtual access to their same doctor or provider so that they can get that direction and get that coordination to the right place. Now, many times, a patient may come in and have multiple medical problems, and we don't feel that it is great care to have them come back for five different appointments for 5 different problems. We feel that they should have enough time to have multiple conditions addressed during that one visit so that it doesn't lead to unnecessary specialty visits or unnecessary additional urgent care or primary care visits. And it's best care to have the same person who knows that person. And I like it when families are all with one doctor because oftentimes there's systems issues, there's family issues. Sometimes there's certain health conditions that run in families. And so, for instance, I get patients where anxiety runs in the family. And so I know that I will address their back pain or their abdominal pain or their headaches differently than someone else that does not suffer from anxiety. And so we're a big fan of having a personal quarterback, having a primary care who knows the values and the goals of that patient because it's different. We don't treat everybody like a widget. We want to make sure that each patient can have that shared decision making. And then there's also the wraparound virtual care so that everything is integrated and run through that quarterback. And I'd like to Hassan take over and talk about the omnichannel data issues that would lead to best practices.
Sure. Thanks, Dave. So as a former benefits leader and actually someone that's worked in hospital management too, so I have a sense for how employees / patients bounce from service to service. They may start a treatment, stop a treatment. If I'm looking at the data, sometimes I'll see people using a point solution for a little bit and then they discontinue it and then they go see their primary care doctor and then they start another point solution. And I've looked back over the years and realized that sometimes what employers do, there's this unintended consequence of creating this fragmentation. When employers set their strategy of like, how are we going to help the employees, how are we going to help the health of our population, they are looking at it with this triple aim lens. So I want to help with the experience, which is usually access, cost, both for the individual and the employer, and definitely quality, which leads to better outcomes. And employers have been using for the past 20 years a very blunt set of instruments, which is either benefit design change or I'm going to tack on a solution to put on top of my health plan. Either because we've run out of solutions or didn't know exactly how we could actually change the healthcare system, we did exactly what we could get our arms around, which is in many cases design and or point solutions. I'm guilty of putting in 50 some point solutions over 20 years and probably led to some of the fragmentation, but then have tried to find ways to wrap things around our employee experience to make sure that they're actually getting some version of a quarterback. So whether we're putting in a concierge program or an advocacy program, something that's going to guide people to actually to better care, to make more informed decision making, to understand both their own health issues and the choices they have to make. So there are a lot of programs that employers have put in to actually kind of put an umbrella or give a, put the arms around the population saying, I need to help you make some of these decisions because you have so many options. And one of the things I realized working at a number of different companies with different populations is that I can't go in and say that I have a solution that's going to take care of everybody and everyone's going to use it, because obviously that's not going to work. And what we've realized is that, obviously with different demographics within a company, different styles, different cultures, different employer perspective on what they want to give, you have to provide solutions that are going to meet each employee where there is. So, for example, when I was at US Foods, a food distribution company, we had part of the population sitting in a management building, many salespeople on the road all day long, driving across county after county. So just those two populations, I would have different needs about how they access care, when, and how they're actually going to use it. We had nighttime warehouse workers. We had people that were in trucks all day long, and again, their healthcare issues needed to be taken care of, and so we had to provide solutions that were going to meet each one of them. So a lot of employers have been working with their health plans, saying how could we do different things, putting together this quilt work of point solutions, and it really comes down to care coordination. And so the benefit leaders, they have this luxury of seeing across data just what happens with their population, and they realize this importance of this quarterback, this guided approach to make sure that someone is actually controlling the care and helping the individual make decisions. I've heard employees at some companies I've worked at say that it's on Monday I use this point solution, on Tuesday I use a different one, on Wednesday I'll go see my doctor, and on Thursday my health plan will contact me. And none of those instances are those organizations talking to each other, which comes down to this data issue. And so employers definitely have an obligation now to say, okay, I'm as a leader, I'm going to help pull all this data together. And so that you see a lot of activity going on, both legislatively and then across just policy groups and employers trying to get a control of the data, get different entities to speak to each other, all with this aim of again, improving the experience, making sure that especially there's no waste in the system, because one of the things employers see is that people will start and stop care, they will get the same tests done at different places. And so with data sharing and really this integrated approach, we can actually eliminate some of that and get to that triple aim experience that we're trying to solve for.
I just want to add to what both David and Hassan mentioned. We touch on here this omni-channel approach, and what we mean by that is something that I experienced being in banking, in the banking industry and financial services, in that how you think about your user, your end customer, in this case the employee and the patient, and how they access care. And we need to think about that from a healthcare standpoint as well. right? So what I mean by that is, for example, you look at what happened in banking. For many years, you went into the branch and did all your you know your banking at the branch, right? So that's similar to on-site or in-personal in care and on healthcare. But over time, we've moved to doing majority of our banking through digital and virtual access. So thinking about it, thinking about the needs of the population, thinking about um, you know, where employees are working, how they're working, and the fact that we have a recent study that was very compelling, I should say, that focused on the fact that there's 5 generations in the workforce today, right? And those generations all are in different life stages and have different needs. So thinking about those needs, thinking about where they access and how care is delivered is really important from an organizational standpoint as you look across all these channels. Okay, David, I want to hand it back over to you to talk a little about what actually good integrated care looks like.
Great. So here's a schematic, and I love how this has got the person in the middle. Notice in the other one, the person wasn't even there, and the person was looking at the healthcare system and trying to figure out where they fit in. Here, the person is in the middle, and the healthcare is surrounding them. And we believe that the primary care needs to surround them. And this is an omni-channel access. So this could be the primary care is going to be available for them through in-person, through text, through a video chat or phone call. And whatever is best for the person for the scenario, that is what we believe that the person should be able to get access to. And notice how the circles around or the specialty mental health, hospital services, long-term prescriptions, and they're bidirectional. So we believe that this is where the primary care and the patient are going to have shared decision making in a partnership to be able to identify what makes most sense for them, for their goals and their values, and then tapping into those in a coordinated fashion so there's not duplications, so there's not medications that are going to interact with one another, so that there's not unnecessary surgeries taking place, and making sure that that patient is getting the personal care and the touch that they're deserving and needing so that we can be able to deliver on the triple aim. What I'd like to do is to take a look at a few different models about how this can happen. And so the next slide, we're going to take a look at three different models of care. I'll talk about the first one, which is direct primary care. And this is the field that I've been in for the last 10 years. And so for those of most people know about direct primary care, but for those that are not aware, it is a membership model, a flat monthly fee that's usually about $80 to $90 per member per month for unlimited primary care. That's care that's preventive, urgent care issues, chronic disease management, and primary care procedures. And that can be through an omni-channel access. Because it's very efficient, there's usually 75% fewer patients. So in our panel, we have usually about 400 to 600 patients per doctor. And as a result, we get a lot more time. Let me give you an example of how this looks for chronic disease management, ER avoidance, and same-day, next-day access. So for chronic disease management, so there are studies that show over 80% of healthcare dollars are because of chronic diseases and their complications. And so we strongly believe that patients that have chronic disease like diabetes, high blood pressure, high cholesterol, we need to have them absolutely tuned up and reversed if possible. And so, for instance, I had a guy that came in, he came in for headaches, and we found out his blood pressure was really high. And he needed to go on 2 blood pressure medicines that day because it was putting him at risk. But he was also overweight and had pre-diabetes. And so we spent a long time talking about some lifestyle changes for him to make. And I met with him weekly, either virtually or in person. He dropped 40 pounds over a few months, got him down to 1 blood pressure medicine. And his blood pressure was much better under control. So it decreases the risk of heart attack, stroke, kidney dialysis, vision loss, and all those things. And our whole goal is to make sure that we are doing the appropriate case management and follow-up so that we can get our patients finely tuned. And it's difficult to do that in primary care that's fee for service because I wouldn't have had the time to do it. But in a system where you've got 75% fewer patients, you can do that. ER avoidance. So direct primary care studies have shown the ER avoidance is about 40% reduced in this setting. And the reason for that is we keep our cell phones on 24/7 and our patients can call us anytime. So for instance, on Saturday, just last Saturday, one of my patients called me up and he's got a history of diverticulitis. And I knew that he had diverticulitis. And so he was having left lower quadrant pain, some nausea and vomiting, didn't have any symptoms of appendicitis. And so I gave him some pain medicine, some nausea medicine, some antibiotics, had him take a bunch of fluids. I saw him on Monday, he was starting to get better. And I just texted him again today. I haven't heard back, but we'll see how he's doing. He's been trending better. Without that type of access, this would have been an emergency room visit, would have been a CT scan, would have been lab work. It would have been $5,000 and probably 6 hours in the ER. That's just what that would have led to. And so our whole goal is to see if we can, for the first several years of my practice, I kept track of every phone call after hours. And I found about 90% of conditions we were able to manage telephonically and then have them follow up in the clinic next business day. And then same day, next day, we keep half of our schedule open for this. And so we want to make sure that we've got access so people can get in for that strep throat so they don't have to go to a urgent care or an ER room unnecessarily. But the also thing is we want to make sure that we can take care of all their issues that day. So for instance, I had a person that came in, she was having pain when she was having to pee. And so she came in, left us a urine sample, and sure enough, she had a UTI. But while she was waiting for the results to come back, she was like, "Oh, hey, Dave, my elbow, I know we talked about my tennis elbow and the brace not working really great. We talked about potentially doing a steroid injection. Could we do that today?" And we said, "Sure." And so while we're waiting for the urine to come back, I drew up some steroid and was injecting her elbow. And then while we're doing that, she's like, "Oh yeah, and I've got a wart on the bottom of my foot. Can we get rid of that too?" And so I said, "Sure, yeah." And so I got the liquid nitrogen, froze that. So she got a 3 for that day. And we feel that it is best care to be able to take care of the patient's needs right then and there and get it done. And that's open access scheduling. So, Paul, would you mind talking about the point number 2?
Sure, happy to. And thanks for that, Dave. I think that's some really important points that you touched on there on access, cost avoidance and quality outcomes, right? You've touched on all those 3 areas we've talked about through that model. But as we know, there's multiple models, right? And it all depends on the organization and frankly, where they started and where they want to get to. And so one of the examples and models of another best practice that we've seen is a large financial services institution, and they had on-site clinics. Now, historically, those on-site clinics predominantly just dealt with what you expect: prevention, wellness, and very low acute types of issues. Occasionally, some occupational health. They decided that over time they wanted to focus more on primary care and start to really address some of these issues that their employees were having. So they chose a location where they had very, very large population, and they used and had some on-site clinics and used that as an opportunity to build out this idea of an integrated approach, an integrated model, starting with primary care. So what they did was they partnered with a virtual primary care solution that also did navigation and coordination, and through them identified a local advanced primary care system practice in the community. They then developed a primary care model on site. So they took it beyond just the wellness and prevention, added primary care services by utilizing doctors from this local near site advanced primary care facility. And employees could still use the on-site care for the prevention, some other things, but other employees could also, if you wanted, you could enroll into the primary care program, and that would be your primary benefit program. Now, they then supplemented that with the near-site care. So they had the on-site where the doctors come in on-site and address some of those primary care issues and some of those other supplementary areas that I just mentioned. They also allowed those employees to access the near-site facility of this advanced primary care practice for things like labs, diagnostics, urgent care, and also to allow family members of that employee to access the same quality of care. I then built a virtual and digital wraparound to provide that supplemental care for those situations where the individual, after hours or wherever it may be, where they may be traveling and they needed to get care. And they utilize that also to provide that care coordination that we talked about, that David talked about earlier, and the importance of that and the need to have that bi-directional care coordination to ensure continuity of care and to minimize that fragmentation as the individual's employees access either on-site, the near site, or the virtual option through this employer. So I think it's interesting. I'll give you some other facts about this specific example. They just started about a year ago. They haven't got comprehensive data yet, but they're starting to get data in around the impact of this model. They put some measurements in place. They're doing some cohort analyses. The reason why I mention that is that it's really important over time to understand which model is best for any specific employer organization. To also think about, does that make sense over time, and to measure against that so you can continue to be able to demonstrate the value of that kind of a model for your organization. I'm going to now pass it on to Hassan. Hassan, you want to talk a little bit about this virtual first model?
Sure. So just in summary, it's sometimes I think it's hard to believe that health plans can evolve and innovate, but there is a time and a place for something. And right now, these virtual first health plans are hitting the market. But some carriers are building things, some point solutions and some point solutions carriers are working together to really address a couple issues that employers have. One is like, how can I offer my employees a real affordable plan? And so actuarially, they can put together something that promotes and incentivizes virtual first care, some of the treatment and services that Paul was describing, but build it into the insurance model so that however they're accessing typically primary care happens in a virtual manner. So that in-person care is obviously always made available through the network as needed, but they're really trying to streamline and get employees to be incentivized to think, okay, I'm going to, if I have an issue, I'm going to connect virtually with my primary care team and talk to them about whatever needs I have. So really exciting things, and I'm sure over the next couple of years there'll be some more evolutions and turns with this. And I know some large employers have actually launched some of them over the past couple of years, and more are looking at it for next year as a way to really meet the needs, especially of a population post-COVID that's definitely more comfortable using virtual services. So let's build it into the insurance product, the benefit design, charge employees less for it, and kind of a win-win. So meeting a lot of different elements of the triple aim there.
Paul and Hassan, for those two solutions, is the employer paying for those for the virtual first plan and the on-site near site, or is it through insurance, or is the patient paying for those solutions?
So for the example that I use, the employer is paying for the on-site, and then they are paying, so there's no cost to the employee for any on-site care. For the near-site care, if you're those employees are enrolled in that program, any primary care visits are no costs. Any other ancillary costs are billed through their self-insured program. So the employer pays for those. There are some cost sharing elements in there. I don't have the details of those with some of those ancillary services. And then the virtual and digital similar is paid by the employer.
It's similar for the health plans. There's a number of different flavors with those. So.
All right. To wrap things up a little bit, we'd like to do is talk about now what does all this mean, and what are some practical steps for employers? That's the lens we're looking at this through, to address this need of integrated care, whether it's in person, on site, virtual. How do we want to think about it? And one of the things we need to do from a practical standpoint to really move the needle. Hassan, I've handed it over to you. Talk a little about some of the points on this page.
Sure, thank you. So we've hit on different aspects of point solutions, and so as Paul and I have seen over many years on the employer benefit side, there are just so many solutions. I think every week different ones pop up, and employers have to figure out exactly where and how to put them into their ecosystem. There are some of them are getting more and more narrow, where they're just covering very small single conditions in some cases. And you can't really argue with their ambitions or their purpose or exactly like what they're trying to solve for. But still the problem is that they all work independent of each other and separately. And so while they're solving a specific issue for a patient who has a need today, they are, again, doing it in isolation. Sometimes I equate it to like a symphony where every instrument is playing by itself in a different room, and together it's actually not making any music. It's just making sound individually. And so the employee is saying, well, the employee is kind of left to actually put these things together. So, an employer has the chance to actually step back and say, like, how do I design a system that's actually going to improve the access to care, and really bring this coordinated approach? So you see more solutions, even on like the chronic condition point solutions, talking about holistic care, where before they may have been only focused on diabetes or cardiovascular care. Now they're looking at as much of the spectrum as they can, adding in mental health, MSK, women's health, fertility, family planning, putting all these things together, even within a virtual aspect, so that they can actually help the employees kind of not get stuck in a siloed point solution approach. So, and I think, and this is what employees need, and also what they expect. They don't want to be just looked at as an individual issue, and they don't want to have to go from doctor to doctor explaining things, carrying their own records with them. They want continuity of care, and they want to make sure that they're not actually stuck trying to figure out their own healthcare journey. So a lot of opportunity, both for employers, actually put things together that will actually help the employees, but also help the system get better, and constantly iterate using data in this coordinated approach. And really excited to see a lot of health plans across the country getting in on it too, and making sure that that the employees actually, whatever virtual care that they need, that it's actually integrated, and there's medical record sharing and constant data sharing, so that both like at a population health level, that we're taking care of people, and that the individual is not stuck in a rut. So yeah, Paul, do you have any other comments?
Thanks, Hassan. I'll provide some additional comments here, and then I'll wrap it up and hand it over to Larry. I think one of the things that we've tried to focus on, we've tried to make clear here, is that there's no one right solution for every organization, right? But the reality is that you need to think about all the components and all the parts as an employer to ensure that you're providing optimal care for employees. And that's on-site, near-site, in-person care and virtual care. And the idea that it needs to be integrated is the key aspect that comes out, that came out of the work that we've done, and that we have seen both Hassan as employers and David as a practitioner. Because it's not just that coordination of care. It's not just the fact that you need data, and data needs to be integrated, but it's that continuity of care as well. So it's clinical it's technical, it's technology standpoint. It's, a design standpoint, how you're designing those programs and delivery systems, and all those things need to be considered. And they are going to be specific to any one organization, because every organization has different demographics and populations within their, within the organization. And so really thinking about that and thinking about which of those pieces makes the most sense, and understanding that if you put them together, or if you're out there trying to pull all these different components, whether it's in-person care or virtual, it needs to be integrated, and to think about that component of it from the beginning. And how do you do that in the most effective way to address those issues that are important to an employer, to the employee, and frankly, to the employee's family. So hopefully we've given you something to think about, and provided some examples that can be useful. Thank you. Larry, over to you.
Sure. Thank you all very much, David, Hassan, and Paul, for excellent background on this topic. As I think David mentioned early on, and Hassan as well, prior to COVID, there wasn't a lot of trust about using a telehealth or a virtual provider. People didn't know where the data was going. They didn't know who they were talking to. What was that kind of connection? And I think during COVID, we did find that people, because they couldn't leave their homes, that in fact that kind of access was nice to have, that you could get on to someone, you could talk to them from your home, you didn't have to travel, you didn't have to get out, and the confidence and trust on the confidentiality of the communications was much increased. So we went from less than 20% of people using a telehealth service to close to 80%, 85% during COVID, and many of them maintaining that. Part of the challenges we had is, as many of our employers and service providers, partners, found that there were not as many people clearly coming into the on-site or near-site brick and mortar facility during COVID. Afterwards, people started coming back again, but there were questions about, okay, so moving forward, many employers had a third-party solution like Teladoc or Doctors on Demand or something like that prior to COVID, and some of them continue to have that. And so I want to ask the panelists, if employers have an on-site or near-site center provider, whether it's a service provider or it's a hospital system that they're using for their on and near site, should they best connect to or maintain a third-party virtual provider relationship, or should they try to offer that virtual care through the same providers that are being delivering care on-site? In other words, to reduce the fragmentation of the data collection and the visits and such, what do you think is the best approach? Or doesn't it matter as long as there's a sharing of data between providers on both ends? So David, what's your thoughts about that?
Sure. Well, so one of the solutions, so when an employer wants to partner with direct primary care, they're independent docs that are across the country, and they want to contract with a number of them. They will usually use Hint Connect, because Hint Connect will tap them into the full national network, so they can be able to choose from direct primary care doctors across the country. However, there's going to be some locations, and all those locations will do both in-person and virtual 24/7. So like I will do virtual, so there's no need to add a Galileo or a Firefly for if a patient is coming to me. However, there's going to be some patients that live in more rural areas where there is not a direct primary care brick and mortar office. And so we partner with Eden, and they are one of our channel partners, and they will offer a virtual direct primary care for all the primary care services. And so that's been our solution and offering for employers that have been interested in a direct primary care plus a virtual for those locations that don't have direct primary care available.
Hassan, how about from your perspective? Should we use the on-site center staffs for virtual care, or continue to contact third parties?
I think ideally, and especially the employees that use the on-site services, if they could get a virtual relationship with them and wouldn't have to explain their history over and over again, it would make sense, but not every employer has that offering or capability. So yeah, I think that would make the most efficient sense and probably good value prop for the employees too.
Paul, what's your perspective on that?
Yeah, I think, it's interesting, like the model that I mentioned before, where what they've done is they partnered with a virtual primary care provider. And so they use their technology and their capabilities to allow that on-site doctor and or nurse to also be available to employees through that virtual platform. So I think the challenge there is that with on-site is usually they're, you know, they're there for specific hours of a day and accessible to all employees for various purposes, right? And so it's balancing that access in person with, because of the hours they keep in person, how do you ensure that or do you also provide access to them on off hours, or is that through, other doctors on the platform? So that's just something they had to think about as they developed it and worked with this virtual primary care provider to balance those needs.
Great, thank you. And Hassan, let me go back to a comment you made about how you had often contracted with multiple types of point solutions. Maybe it's diabetes, and maybe it's wellness, and maybe it's some other kinds of specialty conditions. So if you're an employer who's got an on-site or near-site and you have these other kinds of relationships, should you try to have some kind of contractual agreements to require these multiple virtual into one solution partners to work with and share data with the on-site center? Or how do you ensure that kind of integration with those that you've developed these multiple contracts with?
Yeah, it's a great question, and I'm seeing more and more of that put into employer contracts now with the solution. So asking for the integration, it usually stops at being very specific about what it looks like, because employers not really in the business of dictating the terms of how two medical companies can integrate, but they're definitely asking for it, requiring it, and pushing it more often now. So and oftentimes those companies are competing for patients, so that it's hard for them to kind of want to compete and share data. So yeah, yes, the answer is yes. For 20 years, employers have been trying to get all their vendors to work together, and now they're getting much more serious about it, putting it in contracts and demanding it. And it'll look different for every type of arrangement, but yes, we're hoping more people play nice in the sandbox together and share their toys and data.
I love it when the employer will share their point solutions, and frankly, if they share their whole benefit plan with us. So if they're sending us all of their employees, I want to know everything about their benefit plan. I want to know the deductible, the co-insurance. I want to know what the diabetic point solution is, or the MSK point solution, so that I can be able to utilize those and integrate them in my own practice. Or if they've got some mental health, so I can be able to steer them and be able to help them maximize their healthcare benefit. And oftentimes, if they didn't do that, I wouldn't know, and I wouldn't point them in the right direction. So I love it when we can partner with our employers so that we can be able to maximize and to utilize the solutions that are already in place.
Great, David. Well, let me continue with that, David, if you would. I used to work for a state medical society, and what we found when physicians were doing their history of the patients, really the only thing they ever asked about their employment was, what's your insurance plan and what's the
Yeah.
member? They never asked, do you have an on-site center? What kind of disease management programs are offered, et cetera? How do we get patients to educate their physicians, and how do we get physicians to start asking about what the employer is offering to their patients?
I think it's really tough when you've got a population that has numerous employers. So if I have patients that are coming from 100 different employers, many different healthcare plans, it is really difficult to educate me on all of those. And I think that's going to be a challenge. I've worked in a few different locations, one where I had all of my patients coming from two employers. Then it really worked well because I became an expert on those two healthcare plans and those two health solutions. Currently, I've got about 50% retail, or maybe a little bit more retail, and then a handful of employer patients that are coming into my practice. And I feel like I'm able to know their benefit plans well. But you're right, it is really difficult to get that information if you have a wide range of employers that are sending patients to your practice.
Let's now talk a little bit more about the data sharing. David, as a practitioner, and if you know your patients, again, they have not only the on-site center, but there's multiple virtual providers delivering them. What's the best way to get data shared so that you as the primary can know the totality of the kind of visits and results and experiences this patient has had?
Yeah.
Does there need to be an agreement between, again, all these vendors, virtual vendors with the on-site, so it all feeds into the on-site EMR, or is there
Yeah.
a better way of going about this?
So the data sharing, I actually think I did when I was with a multi-specialty integrated hospital system. The the data sharing was really quite easy with them. I actually think that was one of the big highlights because I got access to all of the notes from everybody in the system. Um, Being an independent doctor that is separate from the hospital systems and groups, I have to rely on the HIEs. So we use Choreo, and so we tap into that. We've got a few specialists that use our same EMR, and so we can be able to share notes seamlessly with those. We do have integrations with the lab and the radiology services. But I think this is an area of growth and it's part of the roadmap to get those integrations between and sometimes players don't always want to they don't want to share their data directly. So we often have to go through the HIE. As much as I would love to be directly integrated with our hospital systems here, so I could have that immediately, I usually have to go through the HIE.
Oh, understood. Hassan, can you talk a little bit about how do you incentivize people to use the virtual care? Is it just like incentivizing people to get their flu shots, or is there a better approach?
Yeah, well, I guess make it easy and make it inexpensive, or maybe not in that order, but definitely employers are playing around with financial incentives. So to the extent that they can offer free care within the high deductible plan, or at least discounted care for preventive services, they want to get all their employees to think, okay, it's just like the old days where we'd say, if you go to the ER, you have to pay this copay. If you go to urgent care, it was less. Same type of delineation with urgent care or virtual care versus in-person care. So just trying to get the employee to think about the cost savings and then the convenience factor at the same time. So, yeah, again, it's different price sensitivities for people, but I know that the employers that are rolling these virtual plans out are really working across the company to actually explain how it works, show how easy it is, and get them to actually try and test it out. So, they're seeing good engagement in their first year that they've rolled them out.
Another issue that we found is we've heard that on the virtual providers, oftentimes there's a higher level of prescriptions being run. People call in or they connect with the doctor, they want a script, the doctor gives it. How do we ensure the quality of care by virtual providers, and that, in fact, that they're, again, matching in what the primary care doctor really wants to do? Comments from anyone? David?
I can guess. So I mean, I actually worked for Teladoc for a little bit when I was in between jobs. Um, the challenge is I don't know the patients.
Hmm.
And I don't know their full story. I don't know the family. And so, and most of the time you're doing kind of urgent care stuff. It's sinus infections, urinary tract infections, lower back pain. And do we overtreat? Yes, I do think. And I think part of it is because you are not the person that knows them. Now, and so Teladoc is an asynchronous system. Now, there's going to be other virtual solutions where there is continuity, and I think that will improve it. I don't have data on this, but I just know when I was doing kind of urgent care through Teladoc, I think that there was an overutilization of antibiotics, which I think is not a great, not great for the patient, for antibiotic resistance, for the gut biome, for side effects and all of those things. And I think it's a challenge because it's fragmented care.
Yeah, and again, that's what we're trying to avoid. So to wrap it all up, let me ask each of you to give perhaps one lesson learned about to ensure we have integrated care between in-person and virtual care. Paul, give me key lesson learned.
Key lesson learned. It's for me, it is the fact that there is no one right answer, and that it's really important to think about and actually to incorporate all of the components in an employer program. So on-site if possible, right? It's not always possible for every organization. In person and virtual, but to be very thoughtful and understand the integration needs to happen. Don't just add multiple solutions every time you have an issue. Really be thoughtful about your organization, your population, and how do you ensure that happens to avoid some of the things and questions that you just asked us.
Thank you. Hassan, your lessons learned?
Sure. So I think from an employer's lens, take a look at your data, usage data, see where your employees are accessing care, not accessing care. Are they getting sicker? And then figure out if your benefits ecosystem is actually helping or hurting the patient experience, and or kind of impeding your progress towards meeting the triple aim goal. So just take a step back and say, if I was going to start over, how would I put this benefits ecosystem together, and actually think about the patient experience first, and then build it out from there.
Thank you. And David?
I would say that for every employee and everybody on the benefit plan, everybody needs to know the go-to. Where do they go? If they hurt themselves, if they've got lower abdominal pain, if they're having a rash that comes up, if they're having a sinus infection, they need a go-to person. They need to have one place, and have that person then be able to either deliver the care directly or to be able to know the exact right place at the right time. That is where we can make this system less fragmented and integrated.
Great, thank you. Paul, David, Hassan, appreciate again your participation. Thank you for those who sat in on the webinar, and look forward to you joining us in the future. Everyone, have a good week. Thanks very much. Talk to you soon.
Thank you, Larry.
Take care.